Your patient's behavior, it's changed overnight. 4 psychiatric hospitalizations, multiple medications that just didn't work. But what if I told you that the real issue wasn't mental illness? It was a bacterial infection that most doctors are actually taught to ignore. I'm Dr. Tom Moorcroft, and I've spent years treating those complex cases that just don't fit into those patterns that we were taught in medical school. And what I'm about to share with you could fundamentally change the way you look at kids with sudden behavioral changes, especially if you're a provider who's working with those treatment-resistant PANS-PANDAS cases that just don't make sense. You know, in medical school, we're taught to ignore infections like Bartonella hen sleigh. You know, it just causes cat scratch disease. It's mild, it's self-limiting, and really, it rarely needs treatment. So basically for most of us, there's really nothing to worry about, right? But here's what they don't tell you. We're only taught about what happens to most people. You know, like the 60 or 70% of people that no matter really what you do, they're gonna get better. The challenge is, what about that other 30 to 40%? Today, I'm going to walk you through a case that was published in the medical literature. It's one that really reveals the diagnostic blind spot that costs so many kids so many years of their lives. Because the thing is, when infections like Bartonella don't follow the textbook presentation, the diagnosis often gets missed because it looks like something that could, really just be severe mental illness. And the biggest problem with all of that is that's when everyone's missing the diagnosis, and these kids and their families are suffering because you don't know what to look for. But again, it's not your fault. You weren't taught about it. But today we're going to dive into that because it's so important. You know, medical school, it only teaches you what to do in those 60 to 70% of cases. But what about everybody else? And what about that kid in front of you right now? So let me tell you about a 14-year-old boy. And this story changed everything that so many of us knew about neuropsychiatric symptoms in children. So this young man developed acute psychotic behavior. Essentially, he had schizophrenia. The severity of the onset was really like the kind that gets you hospitalized like pretty much right away. And he was 4 times. His parents watched helplessly as their son was cycled through all kinds of different psychiatric medicines that didn't work. He was treated even for autoimmune encephalitis, given some IVIG. You know what? It all failed. The standard blood tests for pretty much everything the doctors could think of, well, they were all negative. And meanwhile, the family was living in this nightmare, and they were watching their child disappear right before their eyes into this deep psychosis with no answers and really no hope. But this is where it all gets interesting. Despite all those negative tests, despite all those failed treatments, one observant clinician noticed something very unusual. There are these kind of weird cutaneous skin lesions. They were purplish red, often called violaceous. Some people call them tracts, some people call them striae, but the bottom line was they didn't look like normal stretch marks from growing or from getting overweight. They were purplish red, they were kind of fiery, and they didn't follow the normal skin planes. And also, they were blanchable. And these are 2 of the telltale signs that really help break this case wide open. And the crazy thing about it is most doctors are taught to not even think twice about this. In our training, we're just like, hey, they're stretch marks, they're gaining too much weight. But the astute clinician who recognized these stretch marks as not looking normal realized that they could be a potential sign of an underlying Bartonella infection. Now, remember what I said earlier. The standard blood tests for Bartonella hen sleigh and Bartonella quintana, for that matter, were all negative. When they did special processing on the blood samples, they found Bartonella DNA. And what was really interesting, this is really after nearly 2 months of treatment with one of the standard drugs of choice for Bartonella. And this is kind of the single antibiotic approach that so many of us healthcare providers are taught in our training. The problem was he was still symptomatic and the DNA was still there. And it wasn't until they switched to combination antibiotic therapy that everything changed. His neuropsychiatric symptoms gradually resolved. He came off all the psychiatric medications. Those skin lesions, that red, purple, it all disappeared. And one of the most amazing parts was that he had returned to his pre-illness state. So essentially, he was cured of this mental illness. And it wasn't really a psychiatric disorder. It was an infection that caused autoimmune encephalitis. So yes, they were kind of right looking at PANS, but when they treated with the IVIG, it was in the wrong order. And then when they gave the antibiotics, empirically, the problem was it wasn't enough and also not in the right order. And this is really important. So when we get the proper diagnosis, that's when we can put a treatment protocol together. But you have to pick it up and notice those nuanced symptoms early on, because early diagnosis and early treatment are critical. If you're a practitioner watching this, I want you to think about how many kids you've seen with sudden behavioral changes that just didn't respond to conventional treatment. And then what did you do? How many times have you wondered if you're missing something? Well, you might be. Let's talk about those skin lesions that really crack this case wide open, because this is something that you can start looking for in your practice today. So Bartonella henselae, Quintana, and Bartonella bacilliformis are really fascinating organisms because they're known to promote neovascularization. That's essentially the growth of new blood vessels from old ones. Now, typically we talk about this and we're trained that this is only in people with really severe immune compromise, such as untreated HIV or something of that nature. But what we're finding out more recently is that this can actually happen in immune competent patients too, especially when they have other systemic symptoms that are consistent with Bartonella infection. This is a really important point here because it's pretty easy to find someone who's profoundly immune compromised, right? But a lot of the patients that we're all seeing are not, frankly, conventionally medically defined as being immune compromised. But what about the person who's been infected for a while and has a lot of other stress and a lot of other toxins in the body? These are people who have immune dysregulation that actually allows their bodies to act more like an immune compromised patient. So they are much more susceptible to some of these infections that the other 60 to 70% of people, the normal population, aren't going to be susceptible to. Picture this. Maybe you're seeing a kiddo who's got like some pretty significant new onset behavioral problems, maybe some rage episodes, new onset OCD. They could be having a tic disorder, kind of doing one of these things, or even an auditory or verbal tic, and symptoms that just kind of came out of nowhere. And for me, the way I think about it is if you're meeting with someone who all of a sudden seems to need an exorcism, that's when you have to think about Bartonella-induced PANS. And then the other part to think about is, hey, all of a sudden they have these stretch marks out of nowhere in a skinny person, or maybe they don't follow skin planes, or maybe they've had a surgery and they have a scar, but that scar goes from skin toned or slightly pink to really bright purplish red. So think about that, because when they look like stretch marks but there's something off about them, you got to start thinking about Bartonella here. So like I said, they might be that purplish red, they don't follow those normal skin planes. The other thing is, if you press on them, they blanch. Now, this isn't 100% that they're Bartonella, but a lot of the stretch marks we see from growth or obesity are not going to be blanchable. One of my mentors, Charles Ray Jones, told me about was even ones where you see the stretch mark where in the middle, it's kind of a pinkish, more normal appearing stretch mark, but then at the tips, they can be purplish red, really kind of fiery red, and you push and they blanch there, but not in the middle. So you can actually have Bartonella invading into pre-existing stretch marks, and part of the stretch mark looks more like Bartonella, but the rest of it's not. That's just another clinical pearl that you need to keep in your mind so that you don't miss that one. Researchers have been looking at this forever. They've had a couple of studies where they found things that look like Bartonella in immunohistochemical staining under a microscope. Then they did DNA and didn't find Bartonella. Then they did find Bartonella in some of these stretch marks on another study confirmed by DNA. The thing here is we don't know that Bartonella caused it for sure, but we're starting to see more and more science supporting that interrelationship and that potential connection between Bartonella infection in immunocompetent patients who are presenting with acute onset neuropsychiatric syndromes. The other part that's really interesting to me clinically, because so much of the time we see that the science is way behind where we need to be in the clinical practice. So we're seeing patients like this, we're waiting for the science to catch up, but in the meantime, we need to treat them because they have a real problem right now. And one of the things we'll see is with children who present this way, oftentimes when those tracks are associated with it, not only do their neuropsychiatric symptoms improve with proper treatment, but those track marks go away as well. And what's so cool is that now whether those track marks go away completely or there is a bit of stretching and scarring that's left over, that red purple goes away. It's like an indicator in real time that the infection is leaving the body and the patient is healing. In my practice, I have patients who are completely stunned when I point these out, and they just think it was from growth or being a little overweight. And other people are very aware that these are potentially related with Bartonella. But most of the parents are really just like blown away when they thought these weird stretch marks on their kid were just a part of growing. It's like kind of like the proverbial growing pains, and these are like the growing stretch marks. But when you start to connect the timing of onset with these, and this is where your history is so critical, and the timeline that we take. So if we start seeing these track marks or these stretch marks appearing around the time of the onset of these new behavioral changes, that suddenly helps the picture get much more clear and it looks much less like these stretch marks from growth and a lot more like a potential autoimmune encephalitis from something like Bartonella. But here's the challenge. This is a visual diagnostic clue that's right in front of your face, so easy to evaluate between history and the physical exam, but most providers just haven't been trained to look at this. I know I wasn't trained this in medical school, and that's the thing. But the good news is, once you understand that this is a possible indication of a Bartonella infection, you can't unsee it. This is likely to turn out to be one of the keys that's going to help you solve some of your most difficult cases that have previously stumped you. And here's where this case really highlights another one of the big challenges out there, and it's a place that gets so frustrating both for providers and for families. Even when they correctly diagnosed Bartonella, or at least they made that one of their working diagnoses, the standard treatment approach often fails. And I'm about to explain why that happens. So in this 14-year-old young man, right, despite nearly 2 months of getting the single drug of choice for Bartonella infection, it's the exact medicines that we're all taught in our medical training, he remains symptomatic. And like we said, the DNA of Bartonella was then found in his blood, even after all this treatment. So what went wrong? So Dr. Zhang and his group over at Johns Hopkins discovered something really crucial. And we've talked about this in the field of chronic illness for a long time, but infections, including Bartonella henselae, can exist in multiple forms. One of them is a logarithmic form, and that basically means it's undergoing logarithmic or rapid growth, right? So it's reproducing very quickly. And most of our antimicrobials, particularly antibiotics, are using this rapid growth rate as a way in to get to kill the bug. But there's other phases, right? So they're called stationary phases. If you've heard of things like biofilm microcolonies, or even in Lyme disease, even round bodies, they're these forms of the bug that are really meant for hiding. So they can go into hiding, they might just slow down their metabolism, but either they're evading the immune system, they're evading our antimicrobials, or they're just reproducing so slow that our antibiotics can't do anything to them. And so what ends up happening is, even if our antibiotics knock back some of the bigger population, we have a small population of these slow-growing protected organisms that kind of smolder, and they just maintain a low, stable number of these organisms in the body without, that need for that population growth. And as I mentioned, the big kicker here is that the drugs that we commonly use to treat the logarithmic growth really aren't going to be working for things like these stationary forms. So we have to do other things. And often when we do have to do this, we have to incorporate more than one antibiotic. We have to include things like maybe methylene blue or some botanicals. And a lot of these things are outside the typical conventional approach to medicine. One antibiotic's hard enough to get, but to get 2 of them, or maybe 3 of them. And we know that these are necessary, and in these severe immune compromised cases, people are like, okay to do that in a hospitalized setting. But all of a sudden, when it's an immune dysregulated person who has severe psychiatric illness, we're just gonna put them on like an antidepressant or an antipsychotic. Challenge is, they're not even well controlled, but we're still like, oh, that's all we can do. So we have to start to understand that this is a really important thing. And just because people aren't meeting this classic diagnostic definition of immune compromise, these people are definitely immune compromised through immune dysregulation, and that's why they're staying sick. And then the other problem, when we start to look at the classical approach to these things, and this is what we're consistently taught in medical training for PAs, nurse practitioners, naturopaths, and even MDs and DOs, right? We're all taught the single antibiotic therapy in almost all cases. The problem is, there have been studies showing that if we use something like a macrolide antibiotic, like azithromycin or chlorothromycin, with azithromycin being the drug of choice for Bartonella henselae infections, the problem we run into, studies have shown within as little as 2 generations, which really is somewhere in the neighborhood of 5 to 10 hours, that we can have macrolide antibiotic resistance. And we've known this since at least 2004. So we're kind of way behind the times with our conventional approach to this. And so the authors of those studies and many subsequent studies have looked at this and said, hey, look, we need multiple antibiotics. We need combinations. We need to prevent this resistance, and we need to treat both the logarithmic, and now we're learning much, much more about the stationary form. And the thing about the stationary form, most of our antibiotics don't address it. So we need to do combinations. We need to add in things like methylene blue, or very commonly what we're seeing is botanicals are great for working on different stationary forms. So what we're starting to see a lot more is multiple antibiotics, multiple antimicrobial herbs put together to have the greatest outcome. Unfortunately, what happened for this 14-year-old young guy is they were able to do multiple intracellular antibiotics, and in combination, that was what led to him getting back to his premorbid condition. So if you're a provider who's working with these complex treatment-resistant cases, Bartonella-induced PANS may be your answer for many of them. The thing we recognize about this is those standard protocols, they're just not working because they're not addressing all forms of the bacteria. And by the way, if you're a practitioner looking to improve your diagnosis and treatment of Bartonella and other complex vector-borne illnesses, check out www.lymetraining.org. That's where I teach healthcare practitioners just like you to confidently handle cases just like this with evidence-based protocols that actually work and the real-world support that ongoing mentorship provides, so you'll never have to do this alone again. And now, I think it's worth taking a moment to discuss PANS, right? I've been alluding to this throughout this video. PANS is pediatric acute onset neuropsychiatric syndrome. And while this can be triggered by many different infections, Bartonella is one of the most common ones, and it can be devastating for families. So PANS is characterized by this abrupt onset of cognitive, behavioral, or even neurological symptoms. I mean, many patients or their parents can tell you exactly when it happened. But the other part is that sometimes it's kind of like there's a little behavioral change that they sort of just overlooked, and then they overlook the next one. And so maybe some parents feel that it's more of an insidious onset over time, but that's just, there was an abrupt onset, but it was just small, and it grew and grew and grew over time because the original diagnosis was missed. And unfortunately, once the symptoms get like this, it's often means that we have a lot more work to do than we did if it was caught over here, so that you're able to notice those really nuanced symptoms early in the beginning. And if you're a patient, you can seek treatment. If you're a provider, you're going to be able to notice that and really help prevent people from getting over to the other end of the spectrum, where it's going to be much, much more complicated and much more devastating to deal with. And then the other thing to really think about here, especially with school-age kids, is regression. Whether it's social regression, whether it's learning regression, it could be verbal. So kids performing, at or above grade level, they're in 8th grade, and next thing you know, they're performing at a 3rd grade level. Or maybe their handwriting goes to pot. The other thing we often will see is just behaviors. I mean, it's like a 10-year-old starts acting like a 2-3-year-old, mumbling and using baby talk and stuff. So these are little indicators that PANS may be playing a role. The other two things that pop up a ton in our school-age kids is, one, bedwetting, particularly in boys, where getting through the night dry for a couple of years, and then all of a sudden they have a backslide and they're wet in the bed all the time. The other one is acute food restriction. So that's one you need to be aware of too, because you'll have kids who are eating fine and then they start, looking almost like they have anorexia. But the question is, why? Is this just like a psychiatric illness leading to true anorexia from a psychiatric perspective? Or is this infection-induced autoimmune encephalitis? Is this that pediatric acute onset neuropsychiatric syndrome that's leading to the brain manifesting all these psychiatric symptoms? So it would be like essentially a secondary anorexia. But you can do all the anorexia approaches, and it's not going to do anything if you have an underlying smoldering infection that you've missed. And it's interesting, in this case we've been discussing about this 14-year-old, the Bartonella infection actually induced autoimmune encephalitis. And essentially that's where the infection triggers your body to go after yourself. But the other part is, if you ask me, is there any one thing that could look like PANS and cause all the symptoms of PANS and not look like it? And I'd say yes, that's Bartonella infection. So Bartonella infections in and of themselves can look like PANS, but not be. And they can also trigger PANS, and then you kind of get that double whammy. So Bartonella is one you have to have on your radar, and you have to know how to treat. I'm often amazed, when I go through my questions with parents or teachers, I'm like, and their responses, because I'll ask something like, hey, has the kid ever had a cat bite or a cat scratch? And almost all of them are acutely aware of that. Someone seeking care in our office is aware of Bartonella, and they're thinking about that. So cat scratches, and it's mostly the fleas and the flea poop getting inoculated by the cat scratch or the cat bite. So it's really not the cat's fault, but they are the one who are kind of, inoculating you with it. But the other things that we have to be aware of, especially in school, is lice. Lice are known to transmit certain species of Bartonella. And so I've seen where lice goes through a classroom, then we have acute onset ADHD, acute onset OCD, acute onset rage. and acute onset, the need for an exorcism, right? And so when you have multiple kids in the same classroom, all of a sudden presenting with these different things, they could all be from Bartonella inducing PANS, but that's the thing, the presentation is going to be similar, but also uniquely different in each person. So when I ask, say, hey, did your kid have lice recently? And they're like, oh my God, how did you know that? I'm like, well, we're just going through the list of things that might do it. But it's so important to understand how this can be transmitted. So Bartonella, look at cat bites and scratches, lice, flea bites, spider bites, because house spiders have been found to have Bartonella in them, and they may transmit so many different flies and fleas that could potentially transmit this to you. So it's important to understand the potential mechanisms of transmission so that we can help our patients figure out whether or not Bartonella may be something that they need to look out for. On the other side of this, we do have a controversy kind of floating around of whether or not Bartonella is tick transmitted or not. Now in Europe, we've known since the 90s that Bartonella levels in Ixodes ticks, which are very similar to the Ixodes ticks in the United States called the black-legged or deer tick that transmit Lyme. In Europe, we know that there's more Bartonella in those Ixodes ticks than there is Lyme. But in the United States, there's very little Bartonella that's been actually found in these various ticks. So we're not sure that it's really transmitted by ticks, but it's fairly ubiquitous in our environment, so it's something you need to be aware of because of all those other vectors that we were just talking about. When you understand this connection between Bartonella and PANS, it's suddenly those psychiatric cases that really don't respond the way you would expect to psychiatric medications, they all start to make sense. And I also think that this is another clinical pearl. Now, I think most of our psychiatric illnesses are just deemed kind of psychiatric right away, and we just, go down that rabbit hole. Not only do we need, but our patients deserve and should demand of us to go deeper to see if there's a treatable underlying cause, because very commonly there is. And our kids, they don't need more psych meds. They need proper diagnosis and the treatment of the underlying root cause. And if it's Bartonella infection, let's treat it. If it's too much social media time, let's treat it. If it's too many first-person shooter video games, let's calm down on that and go do something as a family. So what I'm saying today is Bartonella is one of the potential triggers here that can lead to behavioral changes. We should be looking for all of them, but one of the most commonly overlooked ones is Bartonella. And perhaps the most frustrating part of this whole thing is that, and it really stops a lot of people from helping children and making the proper diagnosis, is the testing issue, right? So many of us are, we did Bartonella at one of the local labs and it didn't come back positive. Well, why is that, right? Well, there's a whole bunch of different reasons, especially in immune dysregulated people, that antibodies could be positive or negative. This requires your immune system to be on guard and appropriately recognizing Bartonella as not you, and then making antibody to it. But if it's been a chronic infection or it's a low level of infection, we have research that shows we may not have the same antibody response. And if we have co-infection, meaning more than one infection at a time, which is very common, we have evidence that one or both of those infections, the symptoms will be more confusing and they'll be more intense and they'll be harder to treat. But also the blood tests, they have not been validated to be utilized if more than one type of infection is present in a sample. They've only been done on one infection. So what happens when we have two together? And often what we'll see is that one or both of these, the antibody levels will be much, much lower. And in fact, in babesiosis, which is another tick-borne infection, we see that if you have Lyme disease and babesia together, babesia levels in the blood will be lower and the symptoms will be worse. So we're relying on being able to see this babesia, have an antibody reaction to it, or actually find it. But just because there's another infection there, its level is lower. So we end up being set up for a chronic low-level infection. And in Bartonella, hey, maybe the kid got Bartonella from the cat or from lice, but what about strep and mycoplasma pneumonia and all these other infections that are around in the environment? What if we have 2, 3, 4 of these that's just normal for being in school, and now our kids are exposed to Bartonella? Maybe we don't have a lot of Bartonella floating around, but we have enough to create symptoms, just not enough to have a positive antibody test. So then in this example that we've been talking about, they used advanced testing and advanced DNA approaches to find the diagnosis. But the problem with finding the diagnosis that way is that not everybody thinks about it and not everybody has access to it. So the problem is our standard tests miss this way too often. As practitioners, we need to know when to order which test so we get the right answer. And yes, every once in a while, we need to spend a little bit more out of pocket to get a specialty test that gets the right answer so we can shave months or years off of people suffering. So here's what I've learned from my clinical experience over the past 15 plus years working in this population exclusively. When I see a child that has sudden onset neuropsychiatric symptoms, especially if they have these telltale track marks with that red purple on it, and especially when I hear, oh, they went to the doctor and they said, oh, get here, put them on the psych med, and the psych meds aren't working the way that they do for most people. This is when I have to start thinking about PANS. This is when I have to start thinking about Bartonella. Because what's clear to me from treating these kind of cases for years and years and years now is that when we find evidence of exposure to Bartonella, whether it's that direct test that we all want, the DNA of it or a culture, or that indirect test of the antibodies, irregardless, when we know that they've been exposed to Bartonella and they have the symptoms consistent with it, and we initiate appropriate treatment, patients get better. Our kids get better. And you know, the 14-year-old young man we've been talking about, after all that time, there's 4 hospitalizations and all types of different medical interventions, it turns out that once he got the proper diagnosis and the proper treatment, he completely healed. All the weird colors in his stretch marks went away. His neuropsychiatric symptoms went away. He's off of all psych meds, and he's got his life back, and his family has their child back. And this is why early identification, early diagnosis, and early appropriate treatment are so crucial here. The longer these infections go untreated, the more damage they can do. But when we catch them early and we treat them properly, the results, they're often life-changing. So here's what we've learned today. You know those Bartonella infections? Well, they can present in ways that are way, way far outside the patterns that we learned in our conventional medical textbooks. Bartonella infections can cause serious neuropsychiatric symptoms that mimic mental illness. And those purple-red track marks that don't follow normal skin planes, well, those might not just be from rapid growth or from being a little bit overweight. Those could actually be from Bartonella. And these are a visual diagnostic clue that so many practitioners have been missing. The beauty is, after today's video, you'll never miss them again. We also learned that our standard single antibiotic approach to treatment is generally not enough. Combination therapies and including natural and botanical approaches in with our more conventional pharmaceutical approaches are often needed in combination to get the job done. And that connection between infections and PANS, we need to be thinking about infection, not just psychiatry, when kids have sudden behavioral changes. And then this raises a much bigger question, like if we're missing Bartonella this often, how many other psychiatric cases are actually infectious diseases in disguise? How many kids are suffering needlessly, unnecessarily, because we're not looking for the right things? Or maybe we don't have the right training to identify it. Early identification, diagnosis, and treatment generally leads to the best outcomes. But this is a really complex topic, and awareness is just the first step. So if this is ringing true with you, and you've been seeing kids with treatment-resistant behavioral problems, and you want to understand the bigger picture of chronic infections and how they fit into the people who you're seeing on each and every day, so that you can start to identify these in people where you've otherwise missed them, I invite you to check out www.lymetraining.org, where we dive deeply into Lyme, other tick-borne illnesses, and all these vector-borne illnesses, including Bartonella infections and PANS pandas specifically, so that you're never going to miss this again. I want to say thanks for joining me today. I hope that you learned a lot. If you're a patient or a parent, I really hope that this gave you some information that you're going to be able to use, to be aware up front in case you ever have an exposure to Bartonella, or if you've been suffering, you're going to be able to reach out, talk to your provider, and get some more help. And if you're a practitioner, I hope this has been eye-opening and will allow you to be a little more open-minded and start to diagnose Bartonella and other infections in kids with these treatment-resistant neuropsychiatric symptoms.